Today on the pod, we're looking back at history to understand women's health and women's bodies and why for far too long women were dismissed and shamed. It may be shocking to hear that it wasn't until the 1990s that the government mandated women be included in federally funded medical research. Before that, most of what we knew in medicine was based on studying men. And as a result, much of women's health became dismissed, often as psychological or emotional. While we've certainly seen a lot of change over the years, there's much more to be done. Let's talk about it. Hello, I'm Dr. Diane Reidy-Lagunes from Memorial Sloan Kettering Cancer Center, and welcome to Cancer Straight Talk. We're bringing together national experts and patients fighting these diseases to have evidence-based conversations. Our mission is to educate and empower you and your family members to make the right decisions and live happier and healthier lives. For more information on the topics discussed here or to send us your questions, please visit us at mskcc.org/podcast. I am so honored to be joined by author and friend, the great Dr. Elizabeth Comen. Elizabeth is an oncologist who has dedicated her life and career to taking care of women with breast cancer. She's also majored in history of science and has a passion for understanding the context behind illnesses. Today, she shares her insights from her new, amazing, yet shocking book, All in Her Head: The Truth and Lies Early Medicine Taught Us About Women's Health and Why It Matters Today. It's a collective narrative of how women's health was historically treated, extrapolating from men's health without actually testing women. Equally important, it is a call to action to reframe the conversation around women's health and to understand why we can and should discuss our concerns openly and shamelessly with our healthcare team. Elizabeth, welcome to the show.
Hi, Diane. I'm so excited to be here with you.
You are a breast oncologist and you wrote this remarkable book. Why did you decide to do it?
I think, going back in time, I've always been interested in the context of medicine, as you said, understanding that science, medicine does not get discovered, does not happen in a vacuum, but it's inextricably linked to culture, religion, society, and all these forces that we know are so important when the patient shows up in the doctor's office today. And now, having cared for thousands of women and really been privy to heartbreaking stories unrelated to their cancer in many instances of being misdiagnosed, misunderstood, or simply apologizing excessively when they come to the doctor's office because they're sweating, they didn't shave their legs, they didn't have a pedicure. And I'm giving these trivial examples, but we know they span from the small things to life threatening, and really trying to understand and unpack that legacy that I believe shows up whether we're doctor or patient in the exam room.
Yeah, I think that was one of the most powerful parts to me. Like, why do we do that? We all do that. But there's a history behind why we feel like we have to say we're sorry that we didn't wax our legs when we go to the doctor's office.
I mean, if we think about it, the idea of women apologizing and behaving is a societal thing, right? So we shouldn't be surprised that this infiltrates our approach to medicine, but yet somehow there's this surprising thing when you take a step back, even as a physician. Why are all of these women apologizing to me? When you do a breast exam, a lot of times you have to put your hands over your head, and almost every woman will apologize to me. I'm so sorry, I'm sweating, I'm having a hot flash. And it's really unfortunate to say the least.
As we alluded to earlier, it wasn't until 1993 that Congress passed a law establishing guidelines to include women and underrepresented minorities into clinical research and trials. Elizabeth, what does that translate into in today's world, and what are we missing?
Well, I think we still have so many gaps. There's female specific diseases, there's female predominant diseases, or diseases that are uniquely found in women. And yet, when you look at how we've been studied, so much of it has been done on this reference 70 kilogram white male. Many of the trials for cardiovascular disease, the landmark studies, included tens of thousands of men and not a single woman to look at aspirin or cholesterol medications. And as you said, it was not until 1993 that any study that was done by the NIH was mandated to include minorities and women. But the other thing is, because you and I have both been involved in medical science and medical research, it was not until 2016 that those same studies were required if they included mouse models to include female mice. And the idea was just like, oh my God, even these female mice are too hormonal, so we can't study them. So we'll have to study immunotherapies or these other medications or chemotherapies in male mice. And this has had extraordinary consequences head to toe for women. even in our profession, if you look at chemotherapy toxicity, immunotherapy toxicity, it is greater in women. And in a lot of instances, there's a lot that we don't understand because we've been predominantly looking at how it works, how it functions in male models, male specific cells, or actually male human subjects.
We would be remiss in not recognizing that this is not only an issue about women's health being dismissed. Back in 2022, for our 30th episode, I sat down with our president and CEO, Dr. Selwyn Vickers, and we talked about a gap in trust between minority populations and healthcare institutions. Here's what he had to say. Dr. Vickers, can we talk about race, particularly as it relates to that trust in our healthcare system? How do we improve upon that trust?
For many ways, no fault of our own, our lives as individuals, particularly Americans, are developed and formed, if you would, in incomplete narratives. The narrative that we know is typically our community, our race, our family. And one of the ways I think we can begin to change is by completing the narrative of our lives as humans living in this country and on earth. And the completion of that narrative begins by getting to know and understand the life of someone who is very different than you, both in experience, both in skin color, both in activities and even professions. We have to realize that the greatness of a place like MSK is to treat people from every spectrum of life and understand that if we do the hard work of getting the outcomes for those who are disparate, inherently, we will improve the outcomes of those who've had the most. And there's data to show that when you improve access for those who can't get in, guess what? For those who know the double secret handshake, they can get in easier as well. In fact, you make it better. I think the large burden for American healthcare is to deal with health equity. It cost our country billions of dollars because we don't proactively deal with disease and cancer and screening in the lives of those who don't have access. We pay it on the back end for those who suffer because we didn't choose to deal with it up front.
So, I mean, wow, absolutely amazing. I just want to pick up on some really extraordinary things that he said. He talked about the narrative experience of medicine. And so much of this book that I've written and our care of patients ourselves is understanding what is the experience of illness. Two people can have the exact same diagnosis of breast cancer or any cancer, but how they experience it, how that relates to their background, their history, their lives, their family, their whole world could be two entirely different things. And I truly believe, and the reason why I wanted to incorporate her history into this book is that every body that we're in has a history. And that isn't just our race, that isn't just our religion. It is completely unique to ourselves and our life experience. And the more we can access that and understand that, the better we provide care for ourselves and advocate for ourselves. But the more as physicians, we can really try to invite understanding the stories of the patients that come before us, not just how they survive, but how they thrive. And when it comes to minority communities, I think in writing this book, one of the things that shocked me was just how much there is horrific levels of racism and horrible mistreatment of minorities that becomes compounded when you're a woman. The idea that Black women have a 40% increased mortality from breast cancer, not because they're presenting more with triple negative breast cancer, although there may be a slightly increased incidence of that, but because of access to resources. That's simply unacceptable. Or that so many minorities have their pain dismissed, or the assumption that they can handle pain better, still is a legacy that I think shows up in many medical practices today, and that we have to do a better job of truly listening to people of all backgrounds. The other thing that I thought that was really interesting in what he said is he brought up the economics, right? So one thing that has been shown, not just for minorities, but for women as well, if you don't care about women's health because you just don't care, fine. But I bet you care about your wallet, and I bet you care about your workforce. And the reality is, when you invest in women's healthcare, it redounds to our economy. So it is a no-brainer for us to invest in women's healthcare. Whether you care about us or not, it will affect you because we are the primary caregivers. We're the primary decision makers of healthcare. We are the predominant providers of healthcare and the predominant consumers. So that when we are not well, our whole society is not well. And that includes economically.
You've talked about the need for support at the federal level, and there's a White House initiative going on now that you're a part of. Can you talk to us about that?
So there's the Women's Research Initiative that came out of the White House, that came out of President Biden and Dr. Biden, really saying that there are these enormous gaps in our healthcare system with respect to women and men's healthcare. And now there's a massive initiative to close some of these gaps. And recently, President Biden pledged $12 billion to help to do this. And now there are grants that people are applying for from all different aspects of the ecosystem of our healthcare world. And one of the things that I've really learned from my interactions on this level is that it is going to take a village, and it's not just a siloed in academia. We need government funding. We need government support. We need a groundswell from society to say that women's health matters. We need private funding. We need philanthropic funding. And then, of course, we need institutions behind this work. We cannot do this without the support of academic institutions and making sure that there is energy and momentum behind caring for women.
Absolutely. I do want to go back to something else that you actually write about in your book. We as docs have to nurture and understand the patient, and that the focus that we have on the caring, compassion, and empathy is so critically important, but often gets overlooked and not really rewarded. You are one of those compassionate docs, and I try to be the same. But can you talk about that and what you mean? Because both of us, I think, feel very strongly that we have to care for our patients of today and tomorrow. And yet the idea of really talking to your patient, understanding that patient, and then being aware of things that maybe you're going to make the diagnosis because you took that little extra time often goes unnoticed.
Right. Diane, I have known you since residency when you were my chief resident. And I hope this does not get cut from the podcast, but you have been an extraordinary example from day one that I've met you of the compassionate, empathic doctor who truly listens to patients. And you and I both know that our healthcare system is deeply flawed and deeply imperfect. There are lots of pressures on us beyond the exam room, beyond that doctor-patient relationship, third-party players, insurance companies, where we may have to spend hours arguing for an approved medication with a doctor that's never even met our patient. So the pressures are immense, and it's very hard in many instances to access that. But you and I both know that the best care comes from when we have the time to listen to patients. And there are study after study that shows that women listen longer to our patients. But I want to be really clear. We also know that men can do this beautifully as well. But I think there's a historical legacy to the assumption that women are inherently more empathic. I don't think we're more empathic. I just think we've been told we are supposed to be, and therefore we lean into that kind of feminine spirit. But it doesn't have to be. I think we can really try at least 1% better every day or every year to encourage every physician to be valued for their compassion, to be valued for their empathy. So much of medicine now is billing codes and the bottom line, but the bottom line should always be patient-centered care, and the challenges therein are quite complex.
And you absolutely lead by that example. So grateful for you for that. I also want to talk on another really important topic that you address, which is the shame women feel. And as you said, in society, we sort of normalized it. That shame and inability to sort of speak the truth is because there's history that makes us feel that way. Can you talk to us a little bit more about that?
I think there's a tremendous legacy of shame when it comes to women's bodies, particularly our sexual function. I know you've done podcasts in the past with some of our sexual health experts showing that we are 2 times more likely to ask men about sexual side effects from cancer-directed therapies. And this is an extraordinary example of how this legacy of shame shows up, because I think doctors aren't as prepared, but I think patients also don't feel as comfortable talking about their bodies. There are aspects of our genitalia that in women are literally Latin derived from the word shame. And there is so much of a legacy about an inability to advocate for our bodies, how they should behave both in public and in private. And that unfortunately deeply infects the doctor-patient relationship and how women feel about their bodies and what they feel that they can actually talk about.
Yeah, and for anyone that wants to go back to listen to our Women's Guide to Sex and Cancer, that is episode 12. And you're giving your patients life-saving treatments, but often they do have these side effects that can get swept under the rug. Can you share with us as a breast oncologist how you address that and the importance of having your patients speak up?
I think one of the things I try to do is just put it out there so that we can normalize it. So in the breast cancer space, oftentimes for especially young women, we are putting them into chemical menopause, right? So we're either shutting down their ovarian function or giving them medications that decrease the amount of estrogen in their body. This can be sudden and dramatic. Or for postmenopausal women, we are making their menopausal symptoms worse. This can be joint aches. This can be vaginal dryness. This can be decreased libido. This can be mood changes. This can be fatigue, joint pain. All sorts of things can happen. But specifically when it comes to sexual function, I think it's very important when we're describing these medications and describing the treatment to say, this commonly can happen or this may happen. If it does, rest assured, I'm here for it. Talk to me. Let me know what's going on. There is nothing I haven't heard before. I am not embarrassed. There's nothing, like, just try me. And if you set that up ahead of time, I think it opens the dialogue for when a woman does have a complaint or does have a concern, but setting it up to really normalize that these are tough experiences and that we are here for women. And as patients, to have a little bit of faith that we went into medicine to care for you, and caring for you is caring for all of you. So give us a try. And if you don't like your doctor, you're going to find a new one.
Love that.
Yeah.
Are you optimistic about where the ball's going? Like, do you think that we are in a place where we learned from that history and now we're going to move on?
I hope so. I mean, this work's getting a lot of attention. The White House is interested.
Thanks to you.
The public is interested. You're interested. So I think it really touched a chord. That the title is all in her head. And the number of people that have said to me, I've been told something like that before, or I'm just anxious, or just calm down, or you'll be fine. It's unfortunate that the title resonates with so many women, but that it does tells us that there is a need for this. I am very, very much optimistic. And it isn't just coming from women, it's coming from lots of extraordinary men as well who have partnered in this work and are equally enthusiastic.
What advice do you give to women to help them feel empowered over their health?
Yeah, I mean, this is a little provocative, but if you feel like your doctor doesn't like you or you don't like your doctor, goes both ways. If you have that awkwardness, you got to find another doctor. The other thing I would say is if you're not comfortable maybe advocating for yourself, particularly if you're anxious, because it's really hard to absorb information when you're worried and you're anxious. You got to bring somebody with you, a family member or a friend, bring some questions so that you can have another set of eyes and ears to really listen and bounce back what you're hearing, and so that you can feel more comfortable in the advice that you're getting. And somebody else can say, wait, slow down. I didn't hear that. Can you repeat that again? Let me follow up with another question. And as you said, it's so important to know who's on your healthcare team, right? It's your doctor, it's your nurse practitioner, understanding who you should communicate. Is it via portal message? Is it via a phone call? What is the best way? And then the other really important thing is understanding the Cures Act, the idea that information can be readily available to you even faster than your doctor may have seen it, and that you may want to filter some of that and talk to your doctor about, well, I want to wait for you to read my PET scan before I see it. And unless you do that, it may come to your inbox.
Yeah. Just for those that may not be aware of the Cures Act, that is something that the federal government tells us that we are mandated to put every result on the portal immediately after it is resulted, a PET scan, a pathology result, surgical result. And often it's not necessarily written in English for the layperson to read, and it could be overwhelming. And so I completely agree with you. You know, some patients feel that they really want to do that and they really want to get the information as soon as possible, and that could be helpful and empowering, but it can be overwhelming. And so I think it's just something that you want to make sure that you discuss with your doctor. Elizabeth, thank you so much for joining us. As always, I learned a tremendous amount, and I'm so proud of you.
Thank you so much. And for all that you're doing, I really appreciate you.
Thank you for listening to Cancer Straight Talk from Memorial Sloan Kettering Cancer Center. For more information or to send us your questions, please visit us at mskcc.org/podcast. Help others find this helpful resource by rating and reviewing it on Apple Podcasts or wherever you listen. Any products mentioned on this show are not official endorsements by Memorial Sloan Kettering. These episodes are for you, but are not intended to be medical substitute. Please remember to consult your doctor with any questions you have regarding medical conditions. I'm Dr. Diane Reidy-Lagunes. Onward and upward.